Hello, everybody, and welcome to our podcast. I'm Dr. Michael Richmond, and I'm very excited today to have a patient of mine who's become a close friend, almost family, John Weiss. John is a former executive in a Fortune 500 company, and we're going to talk about his story today of hope, determination, and survival in battling advanced stage pancreatic cancer. And hopefully today, you're going to learn some tips how to navigate a cancer diagnosis because it is not necessarily a death sentence, as John will tell you, but you have to do certain things in order to make sure that you navigate the health system properly and you can hold your doctors accountable and make sure you're getting the correct treatment. Without further ado, I'm going to let John start, and I'm going to stop him a couple times because there's a couple points I want to interject. But why don't you start, John?
Okay, thank you, Dr. Michael. I guess my journey started back in 2020 when my primary care physician couldn't control my high blood pressure and sent me for a sonogram in which they identified a very small tumor on my right kidney. So small that they couldn't do robotic surgery, so wanted to wait for it to grow a little bigger so then they could do surgery. So I waited about 6 months for that to happen. I then went in to have a partial kidney nephrectomy to take that 1.7 centimeter tumor off of my kidney. And then 8 days later, I woke up and I was jaundiced and went to the emergency room and was admitted to the local hospital here
Okay.
in Atlanta.
Okay. So let's stop there for a second. Okay. So John had kidney cancer, everybody. Okay. And to most people, that would be a huge deal. To him, that's nothing. Water under the bridge. But John also was diagnosed about 10 years prior with a BRCA mutation. And I'm sure most of you, especially women, have heard of it, BRCA1 and BRCA2, BRCA. So he had BRCA2. How did he know that? Because his father actually had male breast cancer. Okay. BRCA2 is associated with women with breast cancer, mostly triple negative breast cancer and ovarian cancer. In men, it's associated with breast cancer, which is very rare, prostate cancer, and pancreatic cancer. And about 10 to 15% of pancreatic cancers are hereditary. So we'll go on from there, and John will tell you. So 8 days post-operative from his kidney surgery, he's admitted with jaundice. Okay.
So then they run and do the PET and CT scans on me and inform me that I have a tumor on my pancreas. So I've got pancreatic cancer.
Okay. So now, why is that interesting? And nothing makes me more angry. So understand something. Your right kidney is about this far from your pancreas. Okay. So on maybe 2, 3 CT scans, they missed a 4.8, I think, almost 5 centimeter tumor on his pancreas. The radiologist, and this is in Atlanta, this is at a decent hospital, missed it. Unacceptable. Okay. To be quite honest with you, it's malpractice, but John's not that guy. Okay. And you can't miss it, but they missed it because they focused. Rule number one, as John knows, one of Michael Richmond's rules are you need to look at the report yourself of a scan, no matter what scan you have. You need to look at the report. You need to log into the patient portal. It's very easy to do. You need to look at the report of everything, especially if it's a pathology report. You need to read it. And if there's a question, your doctor needs to look at the scans too. As a surgeon, we're taught you need to look at all the scans yourself and read the radiology report. So clearly somebody didn't do something because this just didn't pop up overnight. Okay, so now John's got this big pancreatic cancer. So continue along.
Yeah. So I went and scheduled appointments with top pancreatic cancer surgeons here in the Atlanta area, 3 of them. And all three of them asked me the same question. Like, why did you go ahead and have robotic surgery on your kidney when you've got this tumor on your pancreas? Of which I can't explain it.
Yeah, you can because they missed it.
So in hindsight, and let me just jump ahead, because under your care and treatment, along with Dr. Selby, which I know we'll get to in a minute, you guys look at all my scans.
Right.
And I can't tell you how many scans I've had where my oncologist or a surgeon comes back with all the alarms going off that something's really bad. Michael, you look at it, Dr. Selby looks at it and says, what are they talking about? They didn't even look at the scan. They just read the radiology report.
Radiology report. Okay.
So many of those incidents occur. So then I'm like, wait a second, I need to go to the best of the best. So I found out who the best was, and I went to Memorial Sloan Kettering in New York City and scheduled an appointment with one of their top pancreatic surgeons, and decided that I would go under their care because I wasn't getting a warm, fuzzy feeling here in Georgia after I just had unnecessary kidney surgery. So that's what I did. Memorial Sloan Kettering treated me and put me on the program.
Okay. So I'm going to stop you for 1 second. So I've written a paper, and there's 5 essential questions to ask your oncologist when you're diagnosed. Most oncologists don't tell you this, and most people don't know to ask. So the first thing is, especially with John, what kind of cancer do I have and what stage is it? Okay. And I'm sure they said to him, you have pancreatic cancer, but every cancer, there's multiple types. So with pancreatic cancer, there's run-of-the-mill pancreatic adenocarcinoma, and there's neuroendocrine tumors, which is what Steve Jobs died of. And the endocrine cells obviously produces hormones, your insulin, glucagon, and then the run-of-the-mill pancreatic cancer is not related to your endocrine system. So did they sit down right away, John, and tell you what exactly cancer it was and what stage, or no?
No. And so I asked him what stage it was, and he said, we're going to have to call it a minimum of stage 3 because they need to have the delineation between the tumor and the mesenteric artery. And the fact that
Mesenteric artery.
mesenteric, yeah, that artery, because that really determines what kind of treatment you could get and
Actually,
whether
it's the
or not
mesenteric
you're
vein. It's the mesenteric vein, but I don't
right.
expect you to know that.
Yeah. They put me on a program of 8 chemo treatments of falfirnone, which they then advanced to 12. So I think 12 is the maximum you can get. And then radiation therapy. The radiation therapy was supposed to last 6 weeks, but Sloan Kettering has advanced radiation technology. They call it high intensity ablasive radiation. So they made a cast, and I would sit in there for 4 to 5 hours a day. And I had to do that for 5 days, every other day, for them to zap the tumor.
Okay, so can I stop you again? So, second question is, John knows now that you always need to ask your oncologist, is my cancer curable? Okay. And they don't like to answer that. It scares them. So if John would have asked them, is your cancer curable? The true answer is yes, but because of, and when we continue on with the story, the true answer at Sloan Kettering was no, which brings me on to the third question you always ask them is, okay, if it's treatable and not curable, how long am I going to live? Weeks, months, or years? So understand, treatable and curable are 2 different things. So John's cancer was potentially curable. Subsequently, when he sought me out way after this, and he'll explain again, it was curable. And for advanced stage, locally advanced stage 3 cancer, we like to give what's called neoadjuvant treatment, which neoadjuvant means prior to doing the surgery. Chemoradiation to try and downstage you, maybe make the operation a little bit easier, but the operation is baked in. So in other words, day one, and he did not know day one because they never told him, which is where the whole story just breaks down. You need to know that day one, when you're diagnosed, that barring any unforeseen problem, you will have surgery within 30 days of finishing your chemo radiation. Okay. And this goes also for esophageal cancer. A lot of people with esophageal cancer get their chemo radiation and they're told they're cured, as we know, John, a mutual friend of ours. And the operation needs to be baked in from the beginning. So John was potentially curable, neoadjuvant therapy, and then planned on an operation. None of this was done. So continue on with now you're in neoadjuvant therapy.
Yes. And Michael, here's the caveat. The plan was chemo, radiation. If it does what it's supposed to do, then they would do surgery. Now, so it was curable, but in hindsight, that surgeon never intended to do surgery on me at all. It's nice to say this is the game plan, but not if the surgeon is never going to be willing to do the surgery.
And explain to everybody what happened, why that happened, and how we figured that out.
So what happened was I finished my last session of radiation, and my oncologist said everything worked as planned. The radiologist that gave me the radiation said it looks like we cooked it and everything looks stable. My oncologist tells me we'll schedule to get back together in a month and we'll talk about next steps as it relates to clinical trial therapy and what kind of drugs you may have to take to keep this at bay.
So understand, John, exactly, everybody. And I said, question, is it curable or treatable? So it was curable, but they never told him that because he didn't ask. So they didn't volunteer. So they're basically, it's treatable. And that's how their whole guide was all along. So when he was done with everything, they should have looked at everything and been like, okay, we are taking you to the operating room within a month. But what they did was they sent him home and said, hey, we're going to decide next steps of treatment. In other words, you're not curable according to our protocol, and we'll just treat you and we'll see how things go and we'll reevaluate, which we speak in common English here, which is bullshit. Okay. Which is basically saying, let's go home and die.
Yeah, I didn't know that because so I had my last treatment on a Wednesday. I asked the oncologist, so what about the surgery? And the oncologist kind of got a little annoyed with me saying, yeah, the surgeon is not prepared to do your surgery, even though all the treatment did exactly what it was supposed to do. But apparently my surgeon was more of a scientist than he is a surgeon and was not prepared to take the risk on of any cardiovascular reconstruction that would be necessary if he had an issue while removing the tumor. So Anita calls her.
Anita is his wife.
Anita, my wife, calls. Anita's college roommate calls Anita on that Thursday, knowing that we were in New York City to get together. My wife tells her that why we were there, and I had just undergone chemo and radiation therapy for pancreatic cancer. Now, Jennifer, the college roommate, helped Michael start up your advocacy service and said, don't worry, Peter, I got this. I'm going to have a doctor call you back in very short. She calls Michael. Michael calls me like 10 minutes later. I give him the story and he said, that's it? I'm like, yeah. And he goes, what else did they tell you? I have to come back in a month and talk about clinical trials and whatever drugs they're going to put me on. And he said, what in the profession, what we call you as a dead man talking. I'm like, what? He said, yeah. Did he tell you how long you're going to live? I'm like, as far as I know, I'm going to just live and take drugs for a while. And then Michael proceeded to tell me what the next 8 to 14 months, if 14 months, would look like and how my body would deteriorate. So I'm like, what the fuck? So I call the oncologist back and I'm like, you're telling me I shouldn't go, like, I asked him 8 times in different ways, what's my runway? What am I looking at in the future? We have different drugs, so it depends on how you respond, yada, yada. And I'm like, and he still wouldn't answer the question. So finally I said, okay, a typical patient with my stage 3, after going through chemo and radiation, how long does the average person live? And he said about 10 to 14 months. Like, it took that much hard work and effort to pull that out of him. Well, why couldn't you just tell me that?
From
So
day
I'm like,
one.
and I said, and you're still telling me that surgery is not an option. He said, no, our surgeon is not prepared to do your surgery. And why would you go ahead with the surgery when the outcome is going to be the same anyway? And you could get any hack to operate on you, but why would you want the last 10 to 14 months of your life be recovering from a surgery that didn't help? I'm like,
Right.
it would give me a chance to live. To
So
start.
does everybody understand? I'm gonna interrupt you again. Does everybody understand this? He was told he had pancreatic cancer. Question 1, what stage? Okay. Then is it curable? They didn't really answer him, but that's the question you need to ask. And you cannot give up. Is it curable? And the answer I would have given him was, yeah, quite possibly. Okay, even though it's locally advanced stage 3 pancreatic cancer. They didn't tell him anything. They basically led him on to think it was, but it was treatable. So then the question is, what treatments? Okay, so they said neoadjuvant therapy, which is the implication is you're gonna have surgery. Okay, then the next question is, what are the side effects of this treatment and what are other options if I don't want this? Okay, so that's question 4. And then question 5, you always ask somebody, the doctor, is where do I see myself the next 6 months? Strapped into a chair, getting chemo, getting radiation. So those are the 5 things. So John contacted me at that point and I believe you sent me the scans and you sent me the report. And I contacted my closest friend who is the head of liver transplant and hepatobiliary surgery at USC. When my book is the finest surgeon I've ever met in my life, Rick Selby. Rick was the initial group who came from the University of Pittsburgh back in the 80s, where liver transplant was started. It was basically the home of solid organ transplantation. And Rick ran their pediatric organ transplantation program. And all in all, he's probably participated in 4,000 solid organ transplants and does what's called the Whipple procedure, which John wound up needing, probably does 2 a week. So there is no surgeon that is more experienced than Rick. So I had presented everything to Rick and we looked at it, and Rick's attitude was, John better get here. Yeah, I think I can do it. I think I can get it out. So what'd you do?
So we had that conversation on Thursday. And you said, how fast can I be in California? I said, I could be there tomorrow. You said, let's meet on Monday. So I flew in on Sunday. You and I met on Monday. On Tuesday, we talked on the phone with Rick. On Thursday, we met in Rick's office and he pulled up all my scan results and had another PET scan done and scheduled surgery for me 8 days later. He dropped the surgery he had scheduled for the next Thursday and slotted me in because apparently there was a sense of urgency before the tumor hardens from the radiation.
Right.
And I had a short window to have the surgery.
And as I said before, when you're diagnosed, if it's potentially curable and you get neoadjuvant therapy, you basically have a 30-day window after radiation to operate, because it becomes like concrete from the radiation, and it's like a bomb went off in there. It's a disaster. It's a bloodbath to try and get the tumor out. So we had a 30-day window to be operated on. Now, the doctors at Sloan Kettering apparently were not capable of doing the surgery, which is mind-blowing. They're surgical oncologists. The problem was it's wrapped around this vein that I guess a lot of, when I've done Whipples in my general surgery practice with Rick, are incapable of doing this or scared to do this. But Rick, being a liver transplant surgeon, knew very well how to deal with it, to reconstruct it if necessary. So John was taken for a Whipple procedure, flew through surgery, was in the ICU for one night. Okay. Subsequently, John needed, and it wasn't that unexpected, a complex vascular procedure. How long was that after surgery?
It was about, I want to say, 3 months.
Right. To
Yeah.
deal with some of the veins he resected, and there were no lymph nodes. Okay. So John has this surgery. And yes, post op, there was a rough go, even though he wasn't in the ICU. Several things happened which were his own fault. We don't need to talk about those. I give him shit every day. But John, now, be 4 years, August?
Yeah. August 12th, 4 years.
Okay, so we're going into our 5th year. People with advanced stage pancreatic cancer who survive a Whipple, they usually recur within the first 16 months. He's almost considered cured. So we use an arbitrary 5 years without anything is cured, but essentially John's cured. And he had no lymph nodes. He had a heck of an operation, a hell of a recovery. If you would have seen him, how much did you weigh at your lowest?
122,
And you're what, 6 feet?
6'2".
And now he's back up into the 160s, 170.
Yeah, 160, 155, 160.
Okay. Eats like a horse. Yeah, can't stop eating. The lesson here is, first of all, and John will talk more, is you need to be your own advocate. And if you can't advocate for yourselves, and most people cannot, you need to find somebody who can guide you through this whole process and hold everybody accountable and make sure that the right thing's done. Because if John hadn't gotten to me he would not be alive today. That's 100%. Okay. And just because somebody thinks they're going to the best place, as John knows, one of my sayings is, you're going to the doctor, you're not going to the hospital. Okay. And just because it's MD Anderson or Sloan Kettering means absolutely nothing. Take a number and stand in line. And we don't need to go into it necessarily, but John's also, because of his job, he's lived in Canada and in Belgium. And for those of you who think medicine is better outside of the United States, you can tell them if you want, or I can say how bad it is in Canada. Okay. And he would have maybe even never even gotten the proper treatment there, since it takes forever. Fortunately, he has great insurance. He was able to go to the doctor of his choice, which, unlike countries, we're the only one that had, but he wasn't treated properly. I'll let you go on from there, and you can share your feelings of what you think about the whole process.
Yeah. You learn a lot as you go through this. First of all, Sloan Kettering should have known, based on my genetic testing, that I'm BRCA2 positive, and the genetic BRCA that I have is predisposed to pancreatic cancer, which also, although that's a bad thing, it's a good thing because typically it doesn't spread to the lymph nodes, which would have given me a better chance of having surgery and everything else, that there's a less likelihood that it spreads. The other thing is, and I know 3 people that I've referred you to, one pancreatic cancer, one esophagus cancer, and another cancer patient, all who would have benefited. And for the ones that did get your service later on spoke volumes about how helpful you were in managing their care. My regret is they waited too long, and that damage had already been done. And my feeling is, had you come on board, maybe they would be here, maybe they wouldn't. But I could tell you that their experience would have been a whole lot better than what they actually went.
Two of them are not alive anymore, correct?
Yeah, and one's barely holding on. And you are 100% accurate in all your diagnoses of all three of these people right from the get-go. And you told me what their program of treatment was going to be and what the flaws with it were going to be. But, and like, I would have given anything to talk to a person like me who has pancreatic cancer or any cancer about, what, John, educate me, which I do. Like, I just live this. One of our best friends up in Canada's daughter died of pancreatic cancer. And I'm like, Lenny, you gotta have a call Michael. And I know you talked about treatment in Canada, and people think, so every time you go to a physician, they always welcome a second opinion. Now, the doctor in the world is going to tell you, no, don't get a second opinion, because everybody's has the same objective, which is your health and survival. Yet people feel compelled when I tell them to call Dr. Michael that my wife's breast cancer oncologist could help me prescribe medication and take care of my esophageal cancer. And I'm so tired of telling people, like, Michael, does that sound like good common sense? You go to a breast cancer oncology doctor.
Right. For
For esophageal cancer. And I can't tell you, I know I mentioned it earlier, how many scans come back and doctors never reading the scan, looking at the radiology report, getting me all worked up. I send it to Michael and Dr. Selby, and they look at it. A surgeon actually looks at the scan and explains it to you in terms that you can understand. And I had so many situations. I could probably talk the next 2 hours about care from infectious disease doctors and all kinds of doctors to put me on medications. They want to take out a port. They want to do this. They want to do that. And I have Michael on the phone, and doctor, I have my
cardiothoracic surgeon who's running my care.
I have a surgeon who's overlooking my care. Would you mind explaining to him what you're explaining to me? And in a very professional manner, you have conversations with these people, and it's a mutual respect. You don't make them feel like an asshole. Even maybe you might tell me that when they do something blatantly wrong, because they don't know my history. Like, for them to want to go out and take out a shunt that it's taken 6 months to get in because they're only swimming in their own lane. Like, where would I be without you? I guess is my question. And no doctor ever wants to take another doctor's prescriptions, say, don't take that anymore. Everybody's afraid. Your primary care physician doesn't carry any weight at all as it relates to medical treatment, especially when you're talking with surgeons and oncology doctors. But if it wasn't for you, like, I take 2 medications a day. I take a Farxiga and I give myself a shot of insulin. That's it. If I had listened to every doctor that prescribed me medications, I'd be taking 14 to 16 pills a day.
Right.
Yeah.
So this is why, as John knows, this is why Jennifer basically came up with the idea to start my company, Paladin MDs, which is medical advocacy and guidance by board certified surgeons, really running all different types of care. We do everything. I do everything, whether somebody has cancer, heart disease, autoimmune disease, because you garner certain respect by cardiothoracic surgeon. And if you treat people with kindness and you're educated, you can give patients actually a roadmap of what to follow. And once you gain the trust of other doctors, they actually find it refreshing because they don't have to talk to nagging families every single day and explain everything, because they got me to agree on what the plan is. And then I can communicate with John. And Rick being my closest friend, it was every single day we would just talk and decide on what to do. And still, until John hits 5 years, I'm still involved with all his care. This is a story, concluding, of that, yes, most people would be dead by now. But if you have advanced cancer, no matter what it is, hope is not lost, but you need John. I call him the human cockroach because he survived. He survived kidney cancer and advanced pancreatic cancer. But if you don't do things the right way from the beginning, you don't have a second chance. Okay. John is so lucky. And if, a great doctor and a good doctor, like John said, has no problem seeking a second opinion. When I was doing heart surgery, lung surgery, I would encourage people to get a second opinion because you want people to feel comfortable with you. And if you don't encourage it, then there's something wrong. Okay. Then you're insecure. And if somebody's not going to listen to me and talk to me about John or another patient, they're the wrong doctor. Find somebody else. Okay. Collaborative. But you gotta, you're the lucky one. Unless you do it from the beginning and do it the right way, all hope is lost, especially in cancer. And regardless of what you hear on the internet, all cancer heads. Okay. There is no cancer that doesn't metastasize. And I'm not saying that Farrah Fawcett would be alive today or Steve Jobs would be alive today, but their cancers were curable. Okay. But they sought out alternative medicine. And by the time it metastasized to stage 4 in both of them, Farrah Fawcett, there was nothing she could do. And Steve Jobs had a liver transplant, but it was in other places. John, do you have anything to conclude with?
Yeah, I just have to say this. I can't go back to my friends that are no longer with us and may have been had they been under your care. And it's frustrating for me to tell people they need to contact you. And just for your listeners, and this is really important. When I first went through this, there was a level of arrogance from the surgeons, from the oncologists. Like I felt I had to record the conversations because I couldn't understand what the hell they were talking about. Nothing was explained in English that I could understand. I almost felt like I was burning them with questions. Once Michael would have a conversation with either a surgeon or an oncologist, and just a real conversation about my care and treatment, there was a noticeable difference on how they treated me as a patient, in the way they explained things to me, because they knew Michael had my back. And I understand people don't want to hurt their doctor's feelings by getting a second opinion and everything else. But as a patient who experienced this, and I see it all the time, people feel like they're bothering their surgeons and their doctors and trying to get answers to simple questions.
And remember one thing, John.
Having you as an available resource has paid volumes to me.
Thank you.
And again, I wouldn't be here without you, Michael.
Thank you. And I want everybody to remember one thing. A doctor's not coming to your funeral. So I'm going to be honest with you. I've said this to plenty of patients. I don't give a crap what they think or what they say. Okay. If they're not willing to answer your questions, if they're not willing to be available, move on. Okay. Find somebody new. Contact me. I'll help you. And obviously I can be found at Paladin MDs, and that's www.paladinmds.com. I'll have that listed at the end of the program. I'm on Instagram at doc4heart. And then our podcasts will be posted on, and it'll be listed in the links on Spotify, Apple Podcasts, and YouTube. And John, if you don't have anything more to say, we can finish up. But thank you for allowing me to care for you. It means the world to me. And I value your friendship and the love that you and Anita have shown me.
Thank you.
So, thank you, everybody.